Well, cardiovascular disease, it's a long term for things that we know a lot about already, which is angina, heart attacks, strokes, and circulatory problems in the legs. So the reason why that's important in the diabetes world is that people with diabetes have a much higher risk of getting cardiovascular disease and circulatory problems. Well, there are lots of contributors to it. People with diabetes tend to be older, so they're more prone to get circulatory problems. They tend to have higher blood pressures. They tend to have abnormalities in the cholesterol and lipid patterns in their blood. They have other metabolic risk factors for circulatory problems. They can get diabetic kidney disease, which increases your risk of circulatory problems, and there are other metabolic changes in diabetes that increase the risk of these common conditions of angina and heart attack and stroke.
Metabolic syndrome is a cluster of abnormalities that an individual may have, and these are: somebody is obese, they have high levels of cholesterol, what's called triglyceride in the blood, somebody's got high blood pressure, somebody's unable to control their glucose properly, so they may have diabetes or pre-diabetes. And there are some other things in the blood which people would be able to measure, which would be higher than they would normally be. So having a diagnosis, having a constellation of conditions, good things and bad things. Does it make a difference at the end of the day? No, but it may increase somebody's awareness that actually I need to be looking for other conditions if this person's got 2 or 3 or whatever.
What happens in this process is that fatty deposits build up within the arteries, so the arteries that supply the legs, supply the heart, supply the brain. And if the narrowing in the arteries becomes significant, then people get impaired blood supply beyond the blockage. So in the legs, if you have a blockage in one of the higher arteries in your leg, then you get claudication, which is where you get pain in your legs when you're walking. If you get the constriction in your coronary artery, then you get angina, which many people will be familiar with, which is a tight, cramping, uncomfortable chest pain due to poor blood supply to the heart muscle. Now, sometimes this narrowing in the artery actually ruptures, and the rupture of the fatty lump in the artery blocks the artery, and that can cause a heart attack. So a heart attack is a blockage in a coronary artery causing permanent damage to the heart muscle, and angina is just a limitation of blood flow to the heart. Well, peripheral vascular disease is where there's furring in the large arteries in the legs, and commonly it doesn't cause any symptoms at all, but it also can cause what's called claudication, which is a nasty cramping pain, particularly in the calves when you walk, and that can progress and can eventually increase your risk of amputation, and it can be very limiting. And people often think that the cramping discomfort they're getting in their legs when they're exercising is just a muscular problem, but it's often a sign of a circulation problem. So if you have diabetes and you're getting cramping pains when you're walking in your legs, then you should always think that you might have peripheral vascular disease. Well, from the cardiovascular point of view, it's very important because the doctor who sees you, whether it's in a hospital clinic or whether it's in general practice, they will always check your blood pressure and talk to you about what your ideal blood pressure target should be. They will always check your cholesterol measurements and make sure that you're taking a statin. And they will talk to you about smoking cessation, and they will also check your feet to check the pulses in your feet, and that's why doctors look at the feet. One of the reasons why doctors look at the feet in a diabetes annual review is to check the pulses in your feet to see if you have circulatory problems in your legs. People with type 2 diabetes are more likely to have slightly higher blood pressures than the background population without diabetes, and again, it's one of the things that people with diabetes don't always pay as much attention to, being very focused on the glucose measurements. But in terms of reducing your risk of eye problems and kidney problems and circulatory problems, then getting good blood pressure control is probably just as important. And most general practices are usually very good at trying to get blood pressure down to target. And the target blood pressure varies from person to person, and clearly people who are in their 40s will have a different blood pressure target to those who are in their 80s. But I think people with diabetes should be talking to their practice nurses and GPs about their blood pressure just as much as they're talking about their blood glucose and saying, well, what's my blood pressure target? And a reasonable sort of target would be around 135, 140 systolic, which is the top of the usual blood pressure readings. Although some people might need a slightly lower reading, and in older people it's often acceptable to have a slightly higher target. Getting your blood sugar control better will probably, over several years, improve or reduce your risks of getting cardiovascular problems, but it's smoking, statins, blood pressure, exercise that are really important in the immediate term. Well, I think if to give people advice about reducing their cardiovascular risk, it's to be as active in reducing your cardiovascular risk as people are active in getting their blood sugars better. So people are very curious about the blood sugars, but the reducing the cardiovascular risk is much less emphasised. So talking to your doctors about exercise programs, losing weight, seeing a dietitian, have a dietetic review, being given a target weight, given a target blood pressure, and talking about statins are as important as concentrating on blood glucose control. Make sure that you don't smoke, so don't start smoking, and if you are smoking then you need to talk to your GP about what's available locally for smoking cessation. The second really important point is that if you're over the age of 40 and you've got type 2 diabetes, you really ought to be on a statin. A lot of people think that they should only be taking a statin if their cholesterol's above a certain level, but that's not quite correct, because the evidence is pretty much that everybody with diabetes over the age of 40 should take a statin regardless of what their cholesterol is. So the trigger for needing statin treatment in diabetes is not your cholesterol measurement, it's how old you are. And if you're over 40 with diabetes, nearly everybody should be on a statin. You should normally try and get your blood pressure as good as it can be, or get to target. And again, that's something most GPs are very aware of. And you need to think about general lifestyle measures like exercise and maintaining a sensible weight. And I think if there was one piece of advice to give to people with type 2 diabetes, is to ask about your cardiovascular risk and what you can do to reduce it. If you have symptoms like claudication, which is this cramping pain in your legs when you're walking, or if you get constant intractable pain in your legs when you're sitting down, then you should think about whether it could be a circulatory problem. If you get angina, which is a cramping, aching chest pain, particularly when you're exerting yourself, or if you have any sort of chest pain, then you should talk to your doctor about it. And I think it's important not to wait for your next annual review, and important not to wait for your next appointment. If you do get chest pain or angina, or if you do get claudication, then you probably need to make an appointment to go and see the doctor sooner rather than later.